Welcome, everyone. We will go ahead and get started in just a moment. How does this look to everyone? Is this in presenter mode or?
No, uh, it's in display mode. It's not in presenter.
All right, let's fix that.
No, one more.
One,
That's
that's
good.
it, Ruhi.
All right. All right, everyone, we're going to go ahead and get started. We have a exciting agenda for you all today. Welcome to our second session of the Obstetric Sepsis Implementation Sprint, and thank you for being here. We're very excited to have you. A couple of housekeeping and frequently asked questions. Yes, this webinar is being recorded and our slides will be available. Our first session was January 20th, and those slides and webinar are currently available on the CMQCC sepsis website. We do encourage that you attend all 4 sessions of the implementation sprint as they all cover unique topics, but they will be recorded and available for viewing. During the webinar, you can drop your questions throughout the session into the Q&A box. You can direct them to a particular panelist if you prefer, but our panelists will be addressing the questions through the Q&A box and the Q&A box only throughout the duration of the webinar. And at the very end of the session, we will be having a live Q&A as well. So we will be going through all the questions in the Q&A box and addressing some live and some throughout the session. Our panelists will be addressing as we go along. We will try our best to provide support as much as possible. So if you have questions that are not answered, please go ahead and let us know. And we would love your feedback. There's a 2-question poll at the very end of this session. Please, please, please give us your feedback. We want to know how we can do better. We do not have any disclosures, and the objectives for our sprint are here for you. They're the same as the rest of the sessions, and we are looking forward to diving into the particular topics of this month's webinar. A quick intro to our implementation sprint team. We have Dr. Main, who you'll hear from today, Dr. Bauer, who heads the sprint team in Michigan, who you also will hear from today, Christa Walczak, and myself, and we together make up the implementation team. You can always reach out to us with any questions.
Good morning, everyone. Our agenda today is jam-packed. We have 7 speakers, so it's been a challenge of organization, but I think we have mastered it. We have 7 big topics: antibiotic stewardship, antibiograms, critical role of order sets, strategies for rapid access to antibiotics, particularly on labor and delivery, prophylactic antibiotics, antibiotic allergies and delivery. And obviously, we're going to be hitting antibiotics. We have a great group of people who are specialists in pharmacy and infectious disease for that. And then we're going to be addressing key questions around chorioamnionitis. How does it fit into our diagnosis and criteria for sepsis that we discussed last session? And then we're going to end with actual other treatment issues besides antibiotics for sepsis, escalation of care, and source control. Like our first session, which was focused on definition and diagnosis of sepsis, This session is really going to be about how you implement things on your unit, on labor and delivery in your own hospital. As a result, we're going to be referencing resources and tools throughout the session today with links and other citations for the CMQCC Sepsis Toolkit and other specific references. So let's get started. Next slide. I want to introduce our first two speakers, who are both antibiotic stewardship leaders in large perinatal centers. Kathy Andonian from Sharp Mary Birch, which is one of the biggest hospitals in California, maternity hospitals in California, and Lauren Puckett here at Stanford, who have been really incredible leaders in this effort. And I want to tell you what I've learned the most about this process is that you need to get to know a good perinatal pharmacist. A good pharmacist is a critical piece of the team. So next slide, I'm going to turn it over to Katie.
Thank you so much, Dr. Main. And let's dive right into what antibiotic stewardship is. It's a coordinated multidisciplinary team that has an effort and a plan which aims to optimize the use of antimicrobials, improve patient clinical outcomes, enhance antimicrobial related patient safety, and of course, slow the rise of bacterial resistance. The CDC has a great guidebook for ASPs for the different types of medical institutions where you practice. And we urge that every OB department have a physician and nurse champion to act as infection and antibiotic stewards to highlight the OB specialized concerns to hospital antimicrobial stewardship programs. Next slide. There is an urgent need for antibiotic stewardship in obstetrics. There are several publications documenting this, that antibiotic exposure during pregnancy and in the peripartum period is becoming increasingly common. Antimicrobial resistance is now a recognized concern in women's health worldwide, and stewardship efforts are needed to evaluate inappropriate antibiotic use to slow this resistance in these relatively young and otherwise healthy patients. Furthermore, women hold 76% of U.S. healthcare jobs. This places women at a higher risk of exposure to resistant organisms. IDSA has great resources on more about this important call to action that I recommend you finding. Resources are there. Next slide. So hopefully I've convinced you of the importance for advocacy of antimicrobial stewardship needs in obstetrics, but here's a simple quick checklist on how to get things started. Getting started depends on if you are implementing a new program entirely at your institution, or perhaps your institution has an existing ASP, but it needs to have and be aware of additional OB needs as a new focus area. Next, you need to identify who are your champions. If you have the resources, I highly recommend working with an obstetrician and or perinatologist. Include neonatology, of course, infectious disease specialists who have a background in maternal health. It's critically important to obtain the support from your hospital leaders. And of course, being a pharmacist, I absolutely recommend finding one of us who are eager to be involved. Understand your resources. This is time and technology. Set small, achievable, and measurable goals that will have meaningful impact that you know of in your OB patient population for your institution. Seek and or offer collaboration. This is a gold standard in the state of California to offer help or seek help with and from other institutions who are trying to breach these goals and advocate for antimicrobial stewardship in obstetrics. Next slide.
I'm going to take it over here and talk a little bit about antibiograms. So antibiograms are one of the most practical stewardship tools we have, but the real value in these comes from how we implement them into everyday decision making. First, for implementation, we have to talk about scope and governance. So who's going to own the antibiogram, who maintains it, how often it gets updated, and where stewardship and microbiology have to really become true partners. But it's not just about sharing data, but agreeing on definitions, inclusion criteria, and how those results be presented. Next, your antibiogram should be designed for action. An antibiogram that only lives in a PDF on a desktop folder is an implementation. It has to show up where clinicians make decisions. That means building quick reference tables, embedding it into order sets, and aligning it with EHR decision support. You also have to decide what you're trying to influence. Is this to refine empiric therapy guidelines, reduce overly broad spectrum use, or support cascading reporting rules, or all of the above? Those choices impact what organisms, sources, and more you emphasize and how you display that data. And lastly, implementation includes measurement and feedback of this, tracking whether your antibiogram informed guidance changes made changes to prescribing patterns, resistance trends, outcomes, and hopefully reducing hospital cost. So your antibiogram isn't a report, it's a tool that we need to intentionally integrate into clinical workflows. Next slide. Next, when we talk about our specialty population, specifically OB and newborns, implementation here needs to be more intentional because we find that these populations don't necessarily fit the standard hospital antibiogram and just doesn't cleanly map onto OB. So defining that population and the sources for this antibiogram, so OB infections, postpartum, newborn infections, those can have different pathogens, profiles, and different empiric needs. Implementation means deciding what gets included and making sure that the microbiology and stewardship here are aligned for those rules. You also need to decide on your drug-bug pairs that matter in OB because susceptibility alone isn't enough. There are pregnancy and lactation safety concerns, IV to PO options, and then feasibility on the unit that should shape what is actually usable. So a specialized OB antibiogram needs to highlight antibiotics people are realistically going to choose in this setting. Third, you need to plan for the small numbers problem. OB isolate counts are unfortunately pretty low. Maybe that's good, but for an antibiogram, that's bad. And so that means that you often have to have multi-year rolling data and combining your data across facilities and potentially health systems. Those choices need to then be explicitly communicated and have those limitations for the antibiogram communicated. So for implementation, the sort of finish of this is connecting it to the product. So having an updated OB empiric guidance, pathway updates, order set tweaks, and education, and then trending that over time and reporting it out. This should be a living, breathing cycle, not just a one-time analytics project. Next slide. Next, we wanted to just include, this as an example from my lovely co-panelist, Katie, of her OB newborn specific antibiogram and how it is organized. So you can see here, this is organized by organism, color-coded susceptibilities, different organism and antibiotic classes, and then urine isolates pulled out as well, since those can also have different susceptibilities and implementations. Next slide. Next, we're going to do the why behind all of this. So why resistance trends matters, and specifically why OB can't rely on national averages. So resistance is changing quickly, especially with multi-drug resistant organisms. So if we build our empiric regimens based on broad national data, we risk missing what's happening in our region, our hospitals, and our units. Susceptibility patterns are local and they can differ a lot depending on your patient mix and practice patterns. I'll call out here that I know our organism trends at in the San Francisco area where I practice are a little bit different than Katie's down in San Diego or in Michigan or in Nashville. OB and L&D populations can have their own exposure risk as well that shift those patterns. The E. coli that grows in your OB populations may look different than the E. coli that shows up in your ICU units at the attached affiliated adult hospital full of 80 and 90-year-old patients. So healthcare contact, prior antibiotic use, and the fact that these patients may have devices or procedures are going to influence what organisms show up and how resistant they are. Implementation-wise, the key message is your empiric pathway has to reflect your local reality. At the same time, though, our goal isn't to create an endless menu of options. It's to have an effective empiric therapy with a streamlined L&D formulary, something that staff can execute quickly, consistently, and especially in time-sensitive situations like sepsis. Newer agents do exist, but we have to balance stewardship with operational simplicity. What's stocked, what's familiar, what's easy to administer, and what keeps the pathway clean. So again, implementation here is to build and revise your OB sepsis bundle or empiric regimens to follow local resistance trends and your local data. Next slide.
Thank you, Lauren. So Incidence and resistance tracking and reporting of your findings is very important in obstetrics. It can be used to reevaluate your empiric antibiotic therapy, as Lauren was mentioning, for both maternal and newborns based on the bugs your institution encounters, the types of infections or sources of infections, and the resistance patterns that are tracked and seen over time. Following one or two key pathogens that affects your OB patient population in your institution is your initial key to success. Depending on your volume of isolates at your institution that you're able to evaluate specifically in your OB patient population, either found by searching in your OB units or by patient type, annually, you may need to look at this data either as a single year in larger institutions or in a rolling multi-year evaluation. You then compare that year to year of your multi-year rolling coupling to look at antibiotic susceptibility trends over time by those antibiotics your institution empirically uses for this specific patient population. You may also wish to work with neighboring medical facilities or medical facilities within your institution's reach to create a regional approach. Next slide. At Sharp Healthcare and Women's Health and for newborns, we specifically trend E. coli year to year by tracking and reporting the observed incidence of ESBL E. coli rates annually. We compare this to our inpatient acute care ESBL E. coli rates as well as to our community. We longitudinally follow susceptibility trends for antibiotics we frequently empirically use for the most common maternal and newborn infections. These susceptibility patterns and trends over time either reassure us that our current empiric antibiotic regimens are okay, or it is time for change. These results help drive our empiric antibiotic options for order sets, give us that reassurance to make sure that we offer the best care to our specific patient populations, the OB care that is needed. We additionally follow Group B streptococci sensitivity to clindamycin. Your institution may eventually also be interested in following Klebsiella pneumoniae and those ESBL E. coli rates or Enterococcus. Next slide.
Thank you, Katie. Our next section will be led by Casey Smiley, who's an internist, specialist in infectious disease, but with a special interest in obstetric infections and is published on them. She's going to be building on the resistance issues documented by our prior speakers and talk about some of the newer antibiotic choices. Next slide.
Thank you all for having me here. I like to start and just kind of go back with, where this data for our empiric regimen of ampicillin, gentamicin, and clindamycin came from. This was originally based on in vitro culture data from the 1980s. So though this has been in practice for many years, we don't have kind of that initial basis of data like we might have with some of our newer agents. So because of these rising resistance rates that we're seeing in many of our antibiograms, as you saw on some of the previous slides, especially with Enterobacterales, so things like E. coli, and especially with clindamycin to some anaerobic pathogens like Bacteroides, this is kind of the reason we need to reevaluate some of these antibiotics. Next slide, please. So this is sort of the way that my mind works as an infectious disease doctor. In general, against most streptococci, your beta-lactams are going to be very effective. For most species of strep, we have very little resistance against beta-lactams. So most of these combinations you're going to see involve some sort of beta-lactam. The harder coverage comes when you talk about those Enterobacterales and anaerobes. And then you can see plus or minus Enterococcus, because although it's not sort of our main pathogen, it's something we want to think about, either if we need to cover it empirically or if it's something we need to add if the patient isn't getting better or maybe if they're getting worse. So as you can sort of see, the general coverage of ampicillin, gentamicin, and clindamycin, while it does cover everything, they all have a little asterisk next to them because we do see rising resistance rates. So you have a lot of other options based on what we need to cover to get that same coverage. And we're going to talk a little bit more about sort of how to choose what's right at your institution for your patients. But in general, there are very many options to cover all of the things that we need to cover. Next slide. One of my papers on this is about sort of some of the issues with gentamicin. And this is really the reason we moved away from gent at my institution. Based on the ACOG guidelines, the dosing is about 5 milligrams per kilogram. But a lot of our new breakpoints, so when we look at an antibiogram, if it says that it's sensitive to gentamicin, that's based on a dose of 7 milligrams per kilogram. And again, you need to check at your institution if that's the case, but really that makes that antibiogram not as helpful if you're underdosing the gentamicin. There are also lowered susceptibility or resistant breakpoints. So species that might have been reported as sensitive are now going to be reported as resistant. And if your facility hasn't upgraded to those breakpoints, that's also something to keep in mind. There are also a lot of side effects in general. It's very nephrotoxic, ototoxic, both for the patient and also for the newborn. There's also rising resistance, which you've seen on these antibiograms, to aminoglycosides in general, including gentamicin. Some of the other issues we'll touch on later is time to receiving antibiotics. These are dosed by weight, so they are not always immediately available. And if you do want to have them immediately available, you need to have some sort of system in place. And there's also no standard nomogram for dosing in pregnancy. So for short term, this is likely not an issue, but as the days go on, we actually don't know sort of what the dose adjustment should be, like we do with other non-pregnant patients. And we know that in pregnancy, there's increased renal clearance. So our dosing can be very challenging. Next slide, please. So kind of leads me into some of the benefits of these newer antibiotics. Specifically, we're talking about piperacillin, tazobactam, and ceftriaxone. So in contrast to a lot of the gentamicin issues, these are readily available in non-weight-based dosing. These come in sort of standard dosing that you can have available on the floor. There's more reliable coverage of that genitourinary flora, so the E. coli, Klebsiella. There's less nephrotoxicity, and actually ceftriaxone, you don't have to dose differently for any sort of renal impairment. There's less ototoxicity, including for the fetus. There's years of safety data. These are not new antibiotics, and they've been in use for quite some time. There's no monitoring or levels that are needed. And overall, these are going to cover more of your flora. So this is going to cover your strep, your Enterobacterales, and plus or minus metronidazole can cover your anaerobes. So overall, you're receiving less antibiotics. Next slide.
Thank you, Casey. We're going to go back to Lauren and Dr. Natali Aziz, who's a clinical professor of maternal fetal medicine with training in infectious disease here at Stanford, to talk about the implementation steps and the importance of order sets. Next slide.
Thank you, Dr. Main, and good afternoon, everyone. The importance of implementation for sepsis management includes and is very critical to the critical process of creating your order sets. Order sets are standardized and they provide care across providers, shifts, and locations. They improve patient safety. They're embedded safeguards that reduce selection and dosing errors. They improve time to antibiotics, and where ideally we want to administer antibiotics within 1 hour. They're tailored for your hospital. They match your formulary and local pathways. They're built for L&D clinical scenarios that are real and applicable to your location. So it includes availability of resources, workflow, turnaround time. They provide decision support at the point of ordering. For example, there's clear defaults and quick options for common scenarios, including allergy alternatives without forcing manual workarounds or hurdles. And of course, there's an accommodation to higher risk scenarios without challenges that may leave us without time, appropriate time administration, and resources. So considering adding options for known MRSA, for example, is an example of doing the higher risk scenarios and incorporating these, as well as considering ESBL and MDRO history. Next slide, please. Sets of order sets there's examples in the CMQCC Toolkit version 2 in Appendix P. We also just wanted to cover the areas of consideration include a clear order set pathway entry criteria. For example, at our center, a variety of words can set you into the order set. For example, OB infection, OB sepsis, chorioamnionitis, endomyometritis will all lead you to this order set. There's a link to the institution pathway as well. And these order sets also include nursing interventions, labs, and of course, antibiotics. And this is an example of the Stanford order set here for antibiotics for OB infection source. So not only do we have chorioamnionitis and endometritis, but there's also things like pyelonephritis, septic abortion, abdominal source, soft and skin and soft tissue, community-acquired pneumonia, hospital-acquired pneumonia, and unknown source. Next slide, please.
So this slide is really the heart of implementation for order sets. So if you want to have better antibiotic decisions through these order sets, it needs to be, the right choice needs to be the easy choice, especially when we're talking about a high pressure situation like sepsis where speed and simplicity matter. So first, plan the medication logistics with pharmacy. No surprise, a pharmacist advocating for working with pharmacy. But I think it's really important because where these antibiotics live in your automatic dispensing cabinet, so a Pyxis or Omnicell, versus in central pharmacy, what about after hours? What's the backup plan? If the drug isn't readily available, people are not going to follow the pathway and they're just going to have to pick something else. Second, we have to operationalize how those antibiotics will run. It's not enough to just give Piperacillin Tazobactam. You have to decide things like, is it standard versus prolonged infusion, clear nursing instructions and default administration instructions. That way there's no ambiguity once you're at bedside. Third, allergy alternatives have to be aligned with your hospital policy. Not just theoretical options. If the pathway recommends something that conflicts with your local allergy guidance or restrictions, it's going to create frictions and workarounds. Next, decision support matters. I feel so strongly about this. A simple list of antibiotics is just not enough. It's easy to make it in an order set, but you're not going to prompt people to find it intuitive, easy, and to use. And building your order set, I think, really needs to involve tying it to risk factors, local resistance, patient characteristics, making it easy and straightforward to use. And then again, don't forget the bundle adjacent orders, things that always travel with sepsis workflows. If they're not built and standardized, they're going to potentially be missed, and that just makes implementation messy and inconsistent. Next slide. One really practical implementation piece that our institution has also discovered through working through these builds is around breastfeeding safety. So the reason this matters, when there's uncertainty, it can be a huge source of last-minute delays and mixed messaging. The principle I like to use, if it's in the OB sepsis order set, it should be breastfeeding safe by design. That sets a clear expectation for providers and staff. You don't have to stop and wonder, can I give this in the middle of a high-stress sepsis evaluation? From an implementation standpoint, this does a few things. One, it's going to reduce delays caused by last-minute questions to pharmacy, lactation, the on-call team. And it should build confidence for clinicians that in these time-sensitive moments, they can execute the bundle without feeling like they're risking harm. It also prevents inconsistent counseling. When an order set standardizes around lactation-safe choices, you avoid the situation where one clinician says it's fine and then another says pump and dump. And that way, families get a consistent messages and hopefully won't be as confused. The last piece here is to make sure that your pathway links to references at the moment they're needed. So I'll shameless plug for the lactation safety appendix that we include in the CMQCC toolkit. That way, when a question does come up, it's a one quick, easy answer away. So design choices that support speed, consistency, and patient-centered care we think are very important. Next slide.
Thank you, Lauren. Now we're going to turn to Natali and Katie for strategies for rapid access to antibiotics on labor and delivery. Next slide.
So one of the most important strategies for rapid antibiotic administration is having a medication dispensing machine. These provide urgent empiric antibiotic at the correct doses that are already available, and they can be placed on labor and delivery, the operating room or postpartum units. There's an override medication list and collaboration that can also occur. This is in collaboration with nursing, medication, safety, hospital leadership, and regulatory agencies. And of course, other strategies for rapidly administering antibiotics includes weight banding doses and grab and go of aminoglycosides. I know that we just spoke about the challenges of aminoglycosides. However, we still have some institutions that use them. And so at Stanford, we are in use of gentamicin still for perioperative antibiotics. And it has been challenging in terms of time and turnaround when we are using weight-based. So in an alternative to weight-based, we actually stratified the weights of our patients based on a 120 kilogram stratification mark, where patients were over or under, and we approximately dosed the antibiotic for 2 mg per gig for perioperative antibiotic administration. And we have 120 milligram bags that are readily available and stored, refrigerated, already on labor and delivery. So patients that weigh less than 120 units receive 2 bags or 240 milligrams, and those that weigh over 120 milligrams receive 360 milligrams or 3 bags. And my partner here, Katie, will be talking about their SHARP experience.
Thank you, Dr. Aziz. So at Sharp Healthcare, and we can stay on that previous slide real quickly. At Sharp Healthcare, we are on the cusp of losing aminoglycoside susceptibilities, as Dr. Smiley mentioned. And we transitioned to tobramycin 7 milligrams per kilogram about 2 years ago. Previously, we were at gentamicin 5 milligrams per kilograms for non-severe maternal infection indications. So in order to make a quick grab and go option for easy access for urgent initiation of aminoglycosides for chorioamnionitis in labor, for example, we took a 10% sampling of patients over 1 year period of time for those that had chorioamnionitis and calculated the average observed weights within 2 standard deviations and calculated what the most common dose might be indicated. So in my patient population, for the sample that was reviewed, 7 milligrams per kilogram, we batch prepare 440 milligrams of tobramycin and store that in our automatic dispensing machines in the refrigerator in batch production that a nurse, after order verification by a pharmacist, can readily remove quickly from the Pyxis machines. Next slide. The CMQCC toolkit has several appendices that are excellent resources for hospitals to have quick access to, including Table 2 and Table 3, which have empiric antibiotic treatment recommendations. These are available again in the toolkit, can be printed and laminated and placed in nursing units, physician charting areas, and my personal favorite in the pharmacy, we have something called the Wall of Knowledge for easy access or for electronic distribution. And we highly recommend using this as strategy number 2 for quick and easy access to choosing the right antibiotic regimen. These can be particularly helpful if your system is unable to implement order sets in a expedient fashion. Next slide. The last strategy for quick access to appropriate antibiotics is understanding which antibiotic should be administered first, which is the broad spectrum antibiotic, or which antibiotics can be co-administered. So in the CMQCC toolkit in Table 4, I also recommend laminating and making this chart available to frontline providers so that they know where and how to access and co-administer, or if co-administration is not possible because the antibiotics are incompatible, which antibiotic should be administered first in severe infection. Thank you. Next slide.
Now we're going to turn to Dr. Deirdre Lyell, who's a professor of maternal fetal medicine here at Stanford and a co-chair and co-principal investigator of CMQCC, to talk about prophylactic antibiotics on labor and delivery. Dr. Lyell, next.
Great, thank you. Next slide. So as Elliott said, I'm going to talk about which prophylactic pre-incision antibiotics to give on labor and delivery. And this is an area that I think a lot of us find can be really confusing. We know that now there are so many different situations with different recommendations, whether the patient is allergic to penicillin or MRSA colonized, already on GBS antibiotics because this is a cesarean that is perhaps done in labor. Maybe your patient's ruptured, and this can over time lead to a lot of incorrect and overuse of antibiotics. But this work demonstrates really that one individual can really start a lot, because the protocols that we use on our labor and delivery came about when Dr. Kelly Fedorak, who's an OB anesthesiologist, wrote out a flow sheet really for herself because she was trying to keep it all straight and get the options straight, because the OB anesthesiologist or the anesthesiologist is the one that hangs the antibiotics often. So just it makes the point that one person really can start a lot. But once that person gets started, it's really the team that can expand it, can help to identify practicality, implement it, and really make it stick. And this was a multidisciplinary stakeholder effort that was led by Doctors Natali Aziz and Dr. Lauren Puckett. And you can see that it really reflects a lot of things that they've already discussed. The protocol, which is in the toolkit, includes a lot of practical considerations, and this is really what we use at one institution. You've heard about the antibiograms being different in different places, so this may not apply everywhere, but these are recommended or based on pretty broad recommendations. Some of the recommendations that we use include weight-based banding. We stock in the cart easy grab and go bags, which also reduces time to give in the antibiotics so they can be hung really quickly, as Dr. Smiley mentioned. It can also save team members time in the operating room so they can focus on the many other things that are going on to get the patient prepared for surgery. And it also supports antibiotic stewardship, including tips on really when to redose and when not to redose. And we're going to walk through that in just a moment. There were a lot of challenges in creating the final flow sheet. The allergy plan is very complicated and difficult to further simplify. And as Lauren already mentioned, the antibiogram keeps changing, and it really takes time and work to keep that up. Next slide. So this is the algorithm. It looks very complicated, but we'll walk through it to make it simpler. The first question or initial breakpoint is really whether the patient has a severe sort of throat closing penicillin allergy. If it's not severe, you give cefazolin on the left. If it is severe, you avoid cephalosporins and move to the right side. So typically Gent and Clinda. And then regardless of if one has a penicillin allergy, if the patient is MRSA colonized, add vancomycin. This is the top two red squares that you see. And vancomycin takes the place of clindamycin for those with severe penicillin allergies. The bottom square is expanded on the next slide, which I'll go through for clarity. So what pre-incision antibiotics do you give for patients already on antibiotics for, say, choreo or ruptured, regardless of labor? And this is actually a little simpler than it seems. If they have choreo, you're going to do what you normally do and add metronidazole. If they're ruptured or in labor, you add azithromycin. And the doses are here on the right for easy reference. Next slide. And then next, we're going to focus on the lower left-hand box that shows what pre-incision antibiotics to give patients who are already receiving group B strep prophylaxis in labor. Next slide. So to make that bigger, first, as shown in the red box at the top left, once someone is already receiving group B strep prophylaxis in labor, when you give pre-incision prophylaxis, you do not need to continue to give group B strep prophylaxis. The baby will soon be delivered, and this also ends the ongoing need. For timing, except for patients who are receiving clindamycin, you can give cefazolin, gentamicin, vancomycin, pre-incision antibiotics immediately, regardless of the timing of their group B strep prophylaxis dose. What's different is if the patient is on clindamycin, then you would repeat that 6 hours after the last dose. Next slide. And then finally, we'll focus on the table on the right regarding specific antibiotic dosing. Next slide. And I want to make just a few key points for practicality. So first, banding you've heard about by maternal weight, those set doses, and this is shown on the left for cefazolin, gentamicin, and vancomycin. Banding has been shown, as you've heard, to result in getting the antibiotic to the patient more quickly, and also freeing the team to focus on the many other important aspects of the patient's care. For redosing of antibiotics, you need only redose antibiotics that are being given for an ongoing problem, such as chorioamnionitis, and not for those routine pre-incision antibiotics. You do not need to redose azithromycin, metronidazole, or vancomycin. And so in closing, this protocol is rooted in judicious use of antibiotics and resources, helps to use resources appropriately and to avoid antibiotic overuse and unnecessary costs. It took a lot for the team to socialize this, so I really give credit to Doctors Natali, Aziz and Lauren Puckett again, who gave multiple presentations at nurse meetings across all shifts. We have 7 practices who deliver in our institution, so they presented at not only the MFMOB division meetings, but to community provider meetings, pharmacy, and it addressed a lot of individual questions as well as had an embedded EPIC protocol, as you've seen. One of the advantages of a protocol like this is that it results in reduced unnecessary and duplicated antibiotics. It is indeed complex. It's posted in our operating rooms. I looked at it last night, and it is really helpful to have that kind of reminder. So I thank them and thank you for your attention. Next slide.
Thank you. Now we're going to go to an important area, which is penicillin allergies and how to delabel them for Dr. Aziz and Lauren. Next slide.
Hi, everybody. So I have the big task of trying to summarize an approach for penicillin allergies, so I'll make it quick. So really, penicillin allergies are going to be one of your biggest implementation make or break areas. Penicillin allergy labels are extremely common, and in most cases, they're wrong. Over 90% of people who report penicillin allergies aren't true allergies, and that means there's a huge opportunity to improve care and avoid unnecessary broad-spectrum alternatives. I think the key implementation mindset here is a penicillin allergy label does not automatically mean no beta-lactams. A reaction to one beta-lactam doesn't necessarily preclude other classes, and if we don't build that nuance into the pathway, we end up defaulting to suboptimal regimens. So what does implementation here actually require? First, to build those allergy alternatives into the pathway in order sets, not leave it to individual clinicians to improvise. That means defining standardized plans for the most common OB scenarios and partnering closely with your allergy, immunology, and pharmacy colleagues so that options are both safe and operationally feasible. Second, we should use structured assessment tools, not guesswork. Again, a plug for the CMQCC sepsis toolkit resources have been implemented to specifically try and support this. So one, how to assess patients with reported reactions, what to do with different allergy histories, and what alternatives make sense. But I do think that the highest yield intervention, and what Dr. Aziz will be talking about on the next slide, is appropriately delabeling when it is appropriate. If we can safely remove an inaccurate penicillin allergy label, we immediately expand first-line options, simplify future care, and reduce downstream exposure to broader agents. That's why penicillin allergy assessment and delabeling should be considered a core implementation strategy, really not an optional add-on. Next slide.
Thank you, Lauren. And with this, I just want to really highlight the importance of penicillin allergy delabeling for the obstetric patient. And this started out very interestingly as a Stanford QI initiative that was led by 2 fellows at the time, Dr. Meryl Sperling from maternal fetal medicine and Dr. Linda Zhu from allergy and immunology. And they took this and made it into a pathway that is now fully functional at our clinic. So first, the patient is brought into care through the OB nurse intake. At that time, the penicillin allergy is identified and it's entered into the EMR. Additionally, the patient is automatically referred to allergy and immunology for intake, and they are given information about penicillin allergy delabeling. Next, at the allergy and immunology clinic, the nurse there who reviews these referrals will send a questionnaire to the patient within a week. Once that has been established, then the patient is actually deemed as eligible for delabeling or not. Now, things that make the patient ineligible include type 2 to 4 reaction or recent anaphylaxis. However, otherwise, many patients will then become eligible for delabeling process, and that moves over to testing, which includes penicillin allergy testing and amoxicillin graded challenge. Once that is established, and if the patient is found to be non-allergic, then the allergy and immunology attending will delabel them in the EMR, and the allergy is confirmed and it still remains in the EMR. But this has been ongoing now for over 2 years and has been very successful. The process, again, the questionnaire is sent within a week. The process is really ideally timed to occur within 4 to 8 weeks, and ideally we want to have this completed by 24 weeks of gestation so that we are ready for any allergy needs that a patient may have by the time of viability. Thank you. Next slide.
Now we're going to turn to the controversial area of chorioamnionitis and how it relates to sepsis and what antibiotics are critical for it. And I'm going to be leading this with Dr. Smiley. Next slide. First of all, what's the definition of IAI chorioamnionitis? ACOG uses multiple terms: intraamniotic infection, chorioamnionitis, suspected intraamniotic infection, temperature over 39 or 38 to 39 with one additional clinical risk factor, or any isolated maternal fever. In ACOG Committee Opinion 7112, which is the last message from ACOG on this in 2017, next slide, they recommend that everyone gets antibiotics. So regardless of what terminology you use, whenever an amniotic infection is suspected or confirmed, or if you have a setting of an isolated maternal fever. And they also point out that while source control, i.e. delivery, is very important, intraamniotic infection rarely it is, if ever, a indication for cesarean delivery. So antibiotics are the mainstay here, and basically fever in labor is going to be a grounds for antibiotics. Next slide. So ACOG recommended in 2017, now almost 10 years ago, ampicillin plus gentamicin or cefazolin plus gentamicin, or severe penicillin allergy, those. And the clindamycin would be added for coverage of anaerobes at the time of delivery, which has been a really big, important addition to add the clindamycin. And in that we have much lower rates of postpartum additional infectious complications, like septic pelvic thrombophlebitis, which is almost unheard of at this point. Next slide. They did recommend at that point 10 years ago that you should be looking at alternative regimens that are also effective, including ampicillin sulfactam, piptazo, and advanced beta-lactams, and with the advantage that some of these actually have coverage built in for anaerobes. Again, this was 10 years ago that we should be entertaining these, but it really is dependent on your local antibiogram, which is why we stressed that so much earlier in this presentation. Next slide.
So when we think about what sort of coverage we want, I know I touched on this earlier. The most common pathogens that we see are what we really want to focus on. Unfortunately, I think I had answered a question in the chat. There's very little culture data, which as an infectious disease physician breaks my heart, because we love to go based on our culture data. So we really have to cover primarily what's in the kind of GI-GU tracts. And most of those are enterobacterales like E. coli, Klebsiella. Enterococcus is more rare, though you should think about it, because in a lot of these different situations, you will use a regimen that does not cover Enterococcus. Enterococcus is not covered by any cephalosporin, which is the mainstay of a lot of these alternative regimens. So it's really important that if you're not covering Enterococcus, you realize that. But in most patients, this isn't going to be the driving factor for their infection. Typically, it's going to be strep or one of your enterobacterales. Anaerobic coverage is also extremely important, especially bacteroides, and especially for those undergoing cesarean delivery. So it's really important to have your anaerobic coverage on board, either with metronidazole or one of those beta-lactams that does have anaerobic coverage. So emerging resistance is a big problem, and so that's one of the reasons we're talking about alternative regimens. Next slide. So these are some options, and as Dr. Main showed before, most of these were actually in the 2017 guidelines. So even though those are almost 10 years old, these were offered as alternatives. And in the guidelines, it actually says to choose a regimen based on your local antibiogram and after discussion with infectious diseases. So some of the ones that we know are in use, for example, at my facility, we use piperacillin tazobactam as a 4-hour infusion. But we've actually talked about maybe switching to ceftriaxone and metronidazole because piperacillin tazobactam is fairly broad. And in some situations, based on your antibiogram, if there's less gram-negative resistance, you can use ampicillin sulbactam or Unison. So again, I know we've sort of stressed it so many times, but it is so important to check your local antibiogram because these are the organisms that are in our community, and that's what you want to make sure you're covering. Next slide. So I was going to talk a little bit about my experience changing our antibiotics here at Vanderbilt. So we looked at our local antibiogram, which should pop up here in a moment. And we actually recommended making the switch to piperacillin tazobactam. Now, this was a few years ago, but as you can see, if we look under our E. coli here, our numbers for pip-tazo were at about 97%. And I know someone's going to make the argument, well, gentamicin's still at 91%. But again, this was based on the higher dosing in non-pregnant patients before the breakpoints change. So that 91% is likely much lower. And I know I don't feel comfortable not covering 10+% of these organisms. So this took a lot of education. We actually came up with OB-specific antibiograms for our groups. There were also a lot of question and answer because our physicians were understandably concerned about making a change, and especially with very kind of set guidelines in place. They weren't very comfortable with piperacillin tazobactam, even though, in infectious diseases, we use that very commonly. So we actually built this into an electronic clinical decision support tool. Next slide. So this is just an example. And I think what I wanted to point out here was there was already sort of a choreo panel that was in use that people were using that had ampicillin, gentamicin, plus or minus clindamycin. So we went ahead and updated it and actually simplified the order set. But as you can see here, it's not just about the antibiotic. There is a lot in this order set. For example, notify the nursery. We do have a note about penicillin allergy, as you can see there, only 15% cross-reactivity with penicillin. We do also have a penicillin delabeling plan in place. Next slide. And then this is the bottom of the order set. So there are a few other things here as well. Next slide.
So I'm going to now address one of the biggest issues that we have with choreo. How do we fit the evaluation for sepsis into our evaluation of serious infections? Intraamniotic infection is a spectrum of severity, as we all have seen. There are some that are 38.0 Celsius with very few symptoms to those who are really sick with sepsis. Many patients with choreo will meet the triggers in the sepsis evaluation flow sheet. They'll have a temp of 38 and a white count of 15 or a pulse greater than 110. So are those really sick enough to have the full labs and evaluation that we would do for a patient with suspected sepsis? I should note that we do draw a full set of labs with every patient who has hypertension, and the rates of death in ICU admission are higher for obese sepsis than they are for hypertension in this day and age. So how do we take a balanced approach to evaluation of these patients? Next slide. So the key step is to lay eyes on the patient. We know that most patients with choreo will be not develop sepsis, but there are some who get very sick. When would you do something? Is the challenge I want to put out, and we are recommending that patients with IAI need evaluation with a CBC or KIM panel if they meet a more advanced screen, i.e. they have either a pulse of 120, like with any pulse sustained for 20 minutes, a respiratory rate of over 24, a temp of 39, or mental status changes or clinical judgment for appears sick or toxic. So we're really trying to separate out the really sickest patients who get more intense evaluation. But this really does involve laying eyes on the patient. So these are the patients that we would really look at for a KEM and CBC panel. Next slide. And these are also the patients that we might consider lactate testing on. Now, lactate is quite controversial. First of all, it is, in this setting, lactate is an assessment of anaerobic metabolism, but it's also elevated in the setting of extended exercise, which is labor. And it actually returns to normal within an hour after active, like running a marathon or after delivery. In the SEPS 3 consensus guidance, lactate is no longer considered a marker of end organ injury, but an indicator of illness severity and partition perfusion. So it's helpful to gauge how sick your patient is, essentially. However, the CMS SEP1 measure, which we're going to talk about most likely the next session, the CMS SEP1 measure calls for lactate measurement in severe sepsis evaluation, but specifically indicates that you should not measure it during labor for the reasons above. When we recently looked at over 1,000 choreo cases with ICD codes for sepsis, we found that a lactate of 2 to 4 was the only indicator of sepsis in 40% of cases, i.e. it was probably overdiagnosed. If that was the only indicator of sepsis was lactate. So again, we're cautious about drawing lactate unless we think the patient is very sick. If a patient has evidence of end organ injury, all guidelines recommend a baseline lactate. So that's really the threshold that we're looking for. The same argument actually goes for blood cultures. Blood cultures are notoriously non-productive for classic choreo. But if the patient is really sick, I think it's a reasonable reasonable thing to draw the lactate, but not in patients, to draw the blood cultures, but not in patients who have what we call mild choreo. Next slide. Now we're going to turn it over for all the other aspects of sepsis treatment besides antibiotics with Dr. Melissa Bauer.
Hi, everyone. So we're going to focus on key treatment recommendations. And this is not just when a patient has screened positive for a serious infection. This is for patients who have end organ injury related to an infection. And in those cases, we need to focus our attention on 3 key tasks. So those are timely antibiotics, and you've heard from our excellent panelists about how to do that, as well as timely fluid resuscitation and restoration of perfusion. And all of these are based on the Surviving Sepsis campaign as well as other sources. Next slide. Rapid antibiotic administration. The most recent Surviving Sepsis campaign recommended that for possible septic shock or a high likelihood for sepsis, we recommend administering antimicrobials immediately, ideally within 1 hour of recognition. And so there's a lot of strategies on how you can do that, but it still is recommended to give within that 1 hour. And I know there's some other sources out there talking about within 3 hours, but there are data to suggest that in pregnant patients, their mortality was higher in patients who didn't receive those antibiotics within 1 hour with sepsis. Next slide. And also fluid resuscitation. We have heard from some of you that there are some concerns about giving too much fluid to pregnant patients. And while that can be a concern, I want to share with you that this is based, what we're recommending and what is also recommended in patients with hypotension related to sepsis, It's recommended to give 30 per kilo within 3 hours. And this is based on height. This is not based on actual body weight. So based on this chart, which is ideal body weight or predicted body weight, depending on your height, if you follow this along here, even someone who's 6 feet tall, the most they would get is 2.2 liters. So I think this is really key that you should have this available for anyone who's writing the order set, or even have it embedded as part of the order set so that they order the exact appropriate amount of fluid. But this is based on height and not weight. Next slide. And also restoration and perfusion. This is really key to avoid further end organ injury. This is important that patients who have septic shock and you need to start administering vasopressors, so patients who you've already resuscitated them, they're still having some hypotension, they do allow in these guidelines to suggest starting vasopressors peripherally to restore mean arterial pressure rather than delaying initiation until central venous access is secured. And this is really key, especially if you have someone with a MAP less than 65. You certainly don't want to maintain that for a long period of time on these patients. And I do want to share with you, I know I've heard from some people, well, maybe we should give phenylephrine because we know we can give that safely peripherally. There was a study that I think is important to note that patients, they examined when there was a shortage of norepinephrine, which is safe in pregnancy, and it is the recommended vasopressor for sepsis and septic shock. And when they looked at the data on that, they did see that in patients who received phenylephrine, because there wasn't any norepinephrine, there was a higher mortality rate. So I would caution to not do that. There are actually a number of protocols out there about giving norepinephrine peripherally. This actually was started in obstetric anesthesiology studies in pregnant patients for spinal-induced hypotension. There's also a protocol that was written by Luis Pacheco that's out there that is written for obstetric patients, and I invite you to take a look at it. Next slide. And then evaluation of escalation of care. That's a really key thing to do when you have these patients. And this is really important because we want to make sure patients are getting the exact surveillance that they need to assess for decompensation. And in the study, when we looked at deaths due to maternal sepsis in the state of Michigan, we noted that many patients died due to failure to escalate care. And that's because the signs of critical illness were not recognized. And then the patient was either, when they were postpartum, placed on a general medical ward or on just a regular labor and delivery bed. The next time that patient was seen, they were either an extremis and sometimes they were deceased. So we want to make sure that we identify when these patients need escalation of care. This is a really great tool. You can use this one or another one that your institution's comfortable with, but this one was retrospectively created and prospectively validated to identify patients who required an ICU admission. So taking a look here, you can see that this is based on a number of vital signs as well as labs. And next slide. I can't remember all of that, but this is to help you here. Perinatology.com. You can just go there and search sepsis calculator and drop down the menus and place what your patient has. If they have a score of greater than or equal to 6, that was associated with an ICU admission. So take a look at that. And there's also some associated papers that were also cited. Next slide. Okay, so now that you have a patient, you're concerned about sepsis, you want to make sure that you have rapid access to help. So critical care specialists that can help you. One thing that you could do is already use the resources that you already have available in your institution, and that's the rapid response team. What we've done at our institution is we have really had it where they collaborate with the obstetrician or the fellow or the midwife or maternal fetal medicine, whoever the specialist is at the bedside. That person has OB expertise. They know what's safe to do in pregnancy, so that when the critical care experts, if they have concerns about whether or not they can give a certain drug or do a certain test, that person is available to collaborate with them to make sure that they're doing all the right things for that patient. And it's really a collective way of doing things. I know that some people have worked to try to have, let's have an OB critical care team. That's really hard to set up. If you're able to do that at your institution, I think I commend you for doing that. But I think that using the resources you already have available and figuring out how you can work collaboratively together is a really great key. The team members vary by institution, and you can certainly use what is going on in your hospital. Next slide. Another key team that you can tap into and help create this is still using the RT team for a consultation. So there are many times that we've had it where a patient, they're not really sick enough to need ICU care. They're kind of in the middle. We're not quite sure what's going on. We need a little bit of maybe some outside eyes on the situation. And the way that it works at our institution is that you can call the RT team for a consult, and they send one member of the ICU team, depending on what you need. Could be the attending hospitalist, it could be the ICU nurse, it could be a number of things. They come to the bedside, they assess that patient, they work with you collaboratively to provide some recommendations. The best thing is they're already aware of the patient in case they decompensate. But also sometimes just having that outward set of eyes, they come take a look and they say, you know what, I really think we should escalate care now. I'm really concerned about this for this reason. But also there are some other things that they can provide benefit for. If it's not the right time to move the patient, such as the patient is just getting ready to deliver, they might be unstable for some reason. They can provide you resources that you may not normally have on labor and delivery. So we've had it where they call it shelter in place, and they can have an ICU nurse come and stay with the patient and titrate pressors or manage the arterial line, which is not a skill set that our labor and delivery nurses usually have. But that's a really nice resource that you can titrate and you can modify for what works best at your institution. And that's it. Thank you. Next slide.
So we're going to close up with talking about the other aspects of sepsis care, which is source control, with Dr. Aziz and myself. Next slide.
Thank you. So importance of source control is really preparedness, and preparedness. It's extremely crucial that we have these things in place prior to our case presentation. So rapid facilitation of imaging, and that includes ultrasound, MRI, CT, whether it be having a protocol in place for pregnant patients, since it's challenging to get pregnant patients imaging, for example, at many smaller hospitals, or whether it be improving the transport time to imaging. For example, at our institution, long ago, we used to have to take our pregnant patients to the adult hospital. And now we actually have them undergo imaging in the children's hospital where it's closer to the patient's location. Second issue is OR access in labor and delivery, having policies in place that make it readily available to have rapid completion for a septic AB, for example, and perform a D&E or a D&C as needed. Rapid access to antimicrobials on labor and delivery is another aspect that we need to consider. And then mobilization of subspecialty services. Again, being at a larger hospital, you have the luxury of having the call system and it's in place. However, for smaller hospitals, it's essential to know the gynecology, interventional radiology, and general surgeons who are on call so that you have the fastest care possible to your patient who is undergoing a serious infection. Next slide, please. In the CMQCC Sepsis Toolkit version 2, pages 57 through 62, there is a table on source control, which reviews the imaging recommendations to identifying specific sources of infection during pregnancy and postpartum. And this includes 3 pages and includes infections like appendicitis, cesarean delivery, cholecystitis, septic AB, for example, and other criteria or diagnoses that meet criteria for source control. Next slide, please. And finally, for sepsis guidance, for specific guidance for septic abortions with changes in reproductive laws, this is essentially more important than ever and is an increasing issue. Key steps include early recognition being very critical. That includes patient education, close physician surveillance, as well as evacuation of the uterus at very timely endpoints. Broad spectrum antibiotics within the hour are essential. IV fluids are essential, and tests for organ and organ injury and monitoring lactate and continual assessment for escalation of care are also things to keep in mind. Next slide.
So I'm going to close with two of the most feared complications, infectious complications of pregnancy, which is invasive group A strep infections. As you may remember, group A strep used to be known as was the cause of infectious childbirth fever, and it can cause streptococcal toxic shock syndrome in adults. We have sent out a 2-page summary of group A strep and necrotizing fasciitis on each side that have the key diagnostic criteria. Here you see the multi-organ involvement and characterized by 2 or more of the following together with hypotension create strep toxic shock syndrome. The next slide gives more detail in a thumbnail sketch for necrotizing fasciitis. This is a key clinical, the key clinical manifestations include erythema, edema, severe pain out of proportion, fever, crepitus, and skin blight. This can occur in any skin break. This can occur, next slide. This can occur with from a vaginal episiotomy or a laceration or a cesarean incision or any skin break anywhere in the body. This is also one where timing is absolutely critical. It advances within hours from being an apparently small infection to one that's overwhelmingly life-threatening, and this remains a significant cause of mortality. So rapid initiation of antimicrobials. If you have time to get a CT images, but you should not delay, it's really about surgical consultation and debridement. While you're doing the debridement, you need to really double down on culture and gram stain, but this is antibiotics and surgical treatment. So that 2-page handout we recommend should be available for reference on labor and delivery because it gives you basically everything you need. If you ever want to see a case of necrotizing fasciitis, you should watch The Pit. Season 2, Episode 5 has a young woman who has necrotizing fasciitis in her legs, and it's really, once you see that, you will remember it. Next slide. So we're going to end with Christa reviewing key points and next steps.
Well, thank you, everyone. The presenters have done a wonderful job of answering many of the questions live in the Q&A box. But if you have any lingering questions, please go ahead and drop them in the box as I review the key points. So every OB department should have an MD/RN infection antibiotic steward or a champion that exists for your unit. Closer connection with our pharmacy and our pharmacists is always ideal. The hospital or regional antibiogram should be reviewed, and antibiotic regimens should be reevaluated annually as things change. Those order sets, you want to make sure that you make the right choice and easy choice for everyone. Standardized approaches to infection save lives. Establish an approach to appropriately triage interamniotic infection and chorio cases. Preparedness is key for responding to serious infections and sepsis. Be sure to create those partnerships with other clinical departments ahead of time. Next slide. So our action steps. So this is that sprint collaborative. So we're throwing a lot at you, but these are things that you can take back to your units and your practice settings to make your own evaluations and move forward with implementing the sepsis toolkit. Meet with your hospital antibiotic stewardship team and review the current local antibiogram. Express your desire to partner and meet with the special needs of obstetrics. Review your current serious infection sepsis protocol and order sets, and think of, do you have any standard antibiotic regimens and do they need to be updated? Do you have barriers to rapid administration of antibiotics, and have those barriers been assessed and addressed? And is escalation of care organized? Meet with your rapid response team to review obstetric cases and discuss protocols that are appropriate for your specific settings. So Ruhi, why don't you go ahead and launch the poll?
All right, everybody should see a poll, just 2 short multi-choice questions on your screen.
And then while that's going on, I think we can review the next 2. So our next session is going to be on March 17th from 12 to 1:30 Pacific time. We're going to focus on patient education and support after severe obstetric event materials. I have to tell you that this is very exciting for me. We've had a very extensive production with the partnership of patients with lived experience on these materials, so that's not one to miss. If you'd like to add any colleagues to attend this sepsis sprint, please reach out to Ruhi directly so that she can send the invite directly. Next slide. Just advertising that we have a big MICPOP perinatal potpourri conference. It's got many, many topics. You just scan this code to register. So let's close with the remainder of the questions. Okay. It looks like you've already answered this one. Oh, okay. Do you only consider lactate greater than 4 to be clinically significant when a patient is in active labor? What about a lactate of 3 along with other signs about possible sepsis? And this is for Dr. Moon.
So this is really gets to the complexity of choreo in labor and choreo in sepsis, which is, we know that labor will raise lactate, and it can raise it up to 4. However, if you have a patient who's, quote, really sick with abnormal vital signs or signs of sepsis, particularly end organ injury, you're going to get a lactate in that setting because you're going to want to follow that over time. Because one of the goals of therapy is going to be making certain that the lactate falls over time. So there are selected circumstances that you're going to want a lactate, but most patients with choreo are not going to need a lactate. Again, unless you have end organ injury for sure. In the ones that are really scary are the ones over 4.
I'm not sure which pharmacist should take this one, but it said, would you be willing to make a grade 1 recommendation for the use of PIP/TAZO over AMP/GENT?
The easy answer is depends on your antibiogram.
That's it, Dr. Main. It depends on your local resistance patterns, your hospital culture. I think that we are coming to the end of the road at my hospital institution based on our local antibiogram, and we have a 2 or 3 year rolling antibiogram, so that always shows us a lag in susceptibility trends. Currently, we're holding on by the grips of our fingernails with Unison and tobramycin dosed at 7 milligrams per kilogram, but certainly we might be moving towards ceftriaxone flagyl, and currently for sepsis of unknown origin without risk or known ESBL current or historical infection or colonization, we use Zosyn for that indication. But I can't speak for everyone else because this is our localized antibiotic susceptibility pattern.
I would argue too that in general, most places it's probably beneficial to move away from aminoglycosides. Now, the alternative is going to be variable, right? In my part of the country, we have really horrible resistance rates. So Amsulbactam is not an effective agent for a lot of our gram-negative organisms, but in certain places, it's very okay. I think the point I would like to make is we need to reevaluate and not just stick with AmpGent. It really needs to be sort of personalized, customized, but it's hard to make an overarching recommendation because it's very different depending on where you are in the country.
I think one of the reasons we've gotten away with AmpGent so long is that most people with choreo are not that sick and they get delivered. They get delivered within 4 or 6 hours. It's the ones that have a really long labor or have some of the really abnormal vital signs that I'm truly worried about. But the most important thing for choreo is probably delivery and not by C-section. You have a C-section on top of an infected uterus, that puts you at extra high risk.
And then it's not written as a question, but I don't know if anyone has comments in response. It says ACOG added a clinical practice update for interamniotic infection in 2024 that says the diagnosis can be made in the absence of fever when other clinical signs are present.
Yeah. Thank you for that. And in fact, you know, when we have the screening algorithm for serious infection and screening for sepsis, fever is only one of the criteria and not a required criteria. And that's really a key thing. In fact, Dr. Bauer can speak to this from her experience in Michigan.
I think that we published a few things, including in the state of Michigan when patients died of sepsis, that they didn't have a fever even then, and 25% of patients. And then in Elliott's work and in my work, it's not specific to choreo, but it's important to know that maternal infection does not always include fever. And we published some really large data sets that 25% of the patients never had a fever, or they had sepsis, had end organ injury. So we're really thankful that they've made that recommendation for choreo too.
I have the ceftriaxone is incompatible with azithromycin. So if a patient is already on azithromycin and it's running, but it is the scheduled time for ceftriaxone, what should we do? Which one takes priority?
Oh, I'd love to answer this. So thank you so much for looking into the compatibility. I also think that it's helpful to have additional IV lines, especially if you're really concerned about a patient, because then you can run that through a separate line and not cause problems with compatibility, especially if you're really concerned about a patient. Now, if you're talking about scheduled antibiotics, then I would talk to your which clinician is managing the patient, and you can determine which one takes priority. But having an additional line to run that through, I think, is a great idea.
Lauren or Katie, you want to address that too?
I'm happy to weigh in too. I think azithromycin is not, I don't want to say not as important, but it is not as important. Ceftriaxone is really doing the heavy lifting. And in general, we have good data in just general sepsis that giving the beta-lactam first is the most important. So in general, it's the most important antibiotic, your beta-lactam, and especially in this case, compared to azithromycin, I think definitely getting the ceftriaxone in first if you only have one line.
Agree. Would just echo that response.
Yep. Thank you. Sorry, I was busy typing in other responses in the chat.
And then I see somebody has a hand up. We're not able to answer questions with voice, so if you could please put your question in the Q&A box. Still in the Q&A says, I'm still not understanding the difference between predicted and ideal body weight. Are we just taking that predicted weight for those under 5 feet? I don't know who answered this one in the chat. So
Melissa.
Sometimes it's better with
Yes. So that table that I posted a link to it. So under 5 feet, I can't remember which way it is. I think it's predicted body weight versus ideal doesn't really matter, but we calculated them for you so that you could have them in there. And that's the only difference. So I'm not saying that you have to, we gave you all the calculations so that you wouldn't have to do that in those tables. They're just called something different, less than 5 feet.
But the difference between now the predicted based on height and predicted weight based on weight is really big in terms of volume of fluid. And you really should pay attention to that. And this minimizes the risk of fluid overload because now you're not giving, a 100-kilogram lady at 30 per kilo is 3 liters. And in most people, that's going to be less than 2 liters in this over 3 hours. So it's a much safer approach.
There are no more questions in the chat. Would any of the panelists like to share anything in closing?
There were a number of questions about SEP1 specifications. We're going to have a long session on that, probably the next session, if not session 3, then session 4. So stay tuned for a long session on CMS SEP1 and how it all fits together.
I dropped in the chat links to the CMQCC sepsis page for anybody that's looking for it, as well as the registration link for the MICPOC conference, as the slide was not up very long. Ruhi, do you want to close us out?
Sure thing. Thank you all so much for joining us. The recording and slides will be available on the CMQCC sepsis webpage in about a week's time. And as always, if you have any follow-up questions that weren't answered today, or if you would like to add any team members, or if you would just like to check in about your own site's implementation challenges about sepsis in the meantime before our March session, please feel free to reach out to me directly at rnath@stanford.edu. We greatly appreciate your time in joining us today, and we look forward to seeing you in March. Thank you so much.
And a hearty thank you to all of our presenters today. We had 7 wonderful presenters. Thank you.
Thank you.